I have no financial relationship with any services or products that are mentioned in this presentation. Recent statistics from the CDC demonstrate a number of injury-related problems in the pediatric age group. 11.9 million children are injured annually in the 2-year survey period of 2009 and 2010, with the distribution seen in this grouping. In the 0 to 4-year age group, matches pretty evenly with the 5-year to 12-year age group and similarly to the 13 to 18-year age group. The groups at risk do differ slightly, and the 5 to 12-year age group is statistically significantly different and slightly less than the other age groups. But one could predict that for every 100,000 children in the population, 151 will be seen in the emergency room for an injury-related problem. The statistics are slightly more daunting as one looks slightly more carefully at it. So accidental injuries, as expected, are one of the most common reasons for urgent and emergent healthcare visits. There are 129,843,000 visits to the emergency room annually in this 2-year survey period. 37.9 million were related to injury-related problems, which accounted for almost 30% of the cases. Of that group with injury-related problems, 8.1 million were in children under the age of 15 years. And if one looks more carefully, open wounds tended to be more problematic, accounting for almost 21% of the injuries that were seen in this age group. Similarly, the National Safety Council reports that an individual seeks medical attention every 40 seconds for a dog bite. This would account for 788,000 additional injuries that may be accounted for in the statistical grouping. So with this large public health problem, the goals of wound care obviously would be for functional closure with minimal scarring, if at all possible, depending on the nature of the injury. Minimal procedural discomfort is particularly important in the pediatric age group. And obviously, one of the most important things is to generate the lowest possible risk of infection. Obviously, the most important step as one sees a pediatric patient with an injury-related wound is ensuring that the patient is stable from a cardiopulmonary and circulatory standpoint. As part of circulation, one would want to make sure that there is adequate hemostasis at the wound. However, for most lacerations, one would be looking at wounds in the secondary survey as one tries to determine the nature of the wound and the best treatment. I'm a big fan of AMPLE as reported by the ATLS group, which includes a quick survey of the past medical history, including allergies, medications, important contributions to the past medical history, which will be important in terms of wound healing, the last meal in the event that the operating room is needed, and the event itself. This can be particularly important in trying to determine if foreign bodies may be present in the wound. Finally, the tetanus status would be appropriate to be determined as best as reasonably possible. The next step after these initial steps are taken is to prepare the wound, and this will include the preparation itself, which we will discuss, the use of local or topical anesthetics, irrigation, perhaps one of the most important parts in preventing wound infection, and finally, debridement of the wound. Tetanus status, as you can see, is currently being measured in terms of the type of wound as well as the date to immunization. With a clean wound, an immunized status, it centers around the 10-year cutoff point, such that if the child has a clean wound and it's been less than 10 years since the last immunization, there is no need for either tetanus toxoid or tetanus immune globulin. If the child has been immunized greater than 10 years prior to this visit and the wound is a clean wound, he should receive a tetanus toxoid, although tetanus immune globulin is not necessary. If the wound is clean, even if the child may not be immunized or the immunization status is unknown, there is no need for tetanus immune globulin, but tetanus toxoid is indicated. The tetanus-prone wound is slightly different. Tetanus-prone wounds are defined as those that are obviously contaminated with dirt, feces, or saliva, and other important qualities of the wound need to be determined, including those with punctures, burns, crush injuries, or injuries with obviously necrotic tissue. This would define the tetanus-prone wound, and as a result of that, tetanus immune globulin would be indicated in those children whose immunization status is unknown or who have had fewer than the 3 tetanus toxoid immunizations. Similarly, the time period changes in that the 5-year time period rather than the 10-year time period is important. Obviously, in terms of closing a wound and treating a wound, patient and wound factors are important as infection risk. Wound factors themselves are important and have been loosely defined as time from injury, degree of contamination, presence of foreign bodies, and the type of injury. Once again, the crush injury. Patient factors are also important in terms of extremes of age, in that the very old do not heal as well, but the very young, under 6 months of age, also have more problems and risk for wound infection. Diabetes, renal failure, malnutrition, obesity, and an immunocompromised status, whether it is a child with inflammatory or autoimmune diseases or a child who is on chemotherapy. Fortunately, most of these factors in most children will not play a role in wound healing. So what are the things that we need to consider as we have now evaluated the wound? Is it possible to treat this wound simply with local anesthetic? Certainly, the teenager may be easily able to be treated with simple injection of local anesthetics, but the preschooler would not. Is the child or the adolescent distractible? Passive distraction, such as TV and movies, can work, although I find them less helpful. Active distraction, including games or a child life specialist, have been particularly helpful in allowing the clinician to inject the wound to anesthetize it as well as to treat the wound. In certain instances, anxiolytics can be very helpful, and both oral and intranasal midazolam have been given. Intranasal midazolam is associated with some irritation, and pretreatment with a dilute lidocaine solution can be helpful. In a more complex wound or a particularly anxious child, ketamine has been helpful. And similarly, in some emergency rooms, although not our own, self-administered nitric oxide has been used to allow the clinician to deal with a more complex wound. In most instances where very complex injuries have occurred, general anesthesia is indicated to help treat the problem. Some of the things that are very important as one considers administering local anesthesia to treat a complex wound would be to administer the anesthetic after checking the distal neurologic status. There's no question that the local anesthesia might affect pinpoint discrimination, and as a result, one might suspect a nerve injury if the anesthetic is administered before neurovascular status is determined. However, once the neurovascular status is determined, one should inject the anesthesia because most children will not allow a reasonable exploration of the wound to determine the depth of the injury as well as the presence of foreign material. For the clinician, it's important to determine whether a topical anesthetic or possibly a local anesthetic with injection is appropriate. Topical anesthetics will be discussed shortly and can be very helpful, particularly in small wounds or with small children. It is important for the treating clinician to be aware of the concentration of the anesthetic, which can be associated with adverse effects, including seizures and cardiac depression. Do a complete evaluation of the wound. It's easier to inspect the wound once it is numbed and irrigated. If there is evidence of injury to the underlying soft tissue, including vessels, tendons, or joints, specialist consultation is likely appropriate. Foreign material continues to be a potential problem and increases the infection risk to the wound. This is particularly true of reactive foreign material such as vegetative matter, such as splinters or dirt. However, even relatively non-reactive matter and material can be a problem with infection, and unless looked for, possibly litigation. It has been reported that litigation related to retained foreign material is associated with a 60% success rate for the plaintiff. As one considers foreign material in the wound, one must necessarily consider the mechanism of injury. A recent gas tank explosion, in my own experience on a boat, led to a moderate total body surface area burn, as well as multiple small lacerations. The lacerations were created by an explosion of a nearby glass that had shattered with the explosion and was only seen on imaging studies and not appreciated by examination. Topical anesthetics remain an important instrument in the armamentarium of the clinician treating open wounds. One of the most popular at this time includes the LET solution or gel, which includes a lidocaine, epinephrine, and tetracaine mix. In some centers, this is referred to as TAL, tetracaine, adrenaline, and lidocaine. The solution or gel can be applied directly to the open wound. The solution itself needs to be applied with cotton balls and then covered with a bandage until the anesthetic effect is achieved. It is important not to exceed the 4 milligram per kilogram lidocaine dosing in these open wounds. One of the important considerations for solution or gel is that the gel should be irrigated from the wound before closure. With the gel application, the parents are encouraged to continue to apply the gel with cotton tip applicators until the wound is completely numb. This is safe for application into the open wound itself, and the anesthetic effect lasts approximately 40 minutes after the gel or cotton ball are removed from the wound. One of the important things to remember, of course, is that the epinephrine solution at 0.1% is approximately 100 to 200 times more concentrated than the epinephrine concentration in the typical local injection, which is at 1 to 100,000 to 1 to 200,000. Therefore, this solution should not be used on areas with end arterioles such as digits, penis, ears, and nose. EMLA cream, which refers to the eutectic mixture of local anesthetics, is a 2.5% lidocaine and prilocaine gel. This solution should not be applied into open wounds, but does work well on the skin nearby, although the effect takes much longer, not working for approximately 60 to 120 minutes. Injectable anesthetics remain the mainstay of treatment and creation of local anesthesia in the emergency room and in the office. The most common, of course, are lidocaine and bupivacaine. The onset for lidocaine is usually within 1 to 2 minutes, and even with that epinephrine solution is between 90 seconds to 3 minutes. Bupivacaine itself has a much longer onset of action, not having an appropriate onset for almost 8 to 12 minutes. I often tell the residents that if they inject bupivacaine alone, that they should go see another patient before they come back and test for anesthesia. Despite the longer onset, bupivacaine does have the advantage of a much longer anesthetic, lasting approximately 3 to 6 hours, whereas the lidocaine effect lasts approximately 1 to 2 hours. The dose with epinephrine is somewhere between 0.7 to 1 milliliter per kilogram for lidocaine, where it's almost 1 milliliter per kilogram for the 0.25% bupivacaine mixture. The dose with without epinephrine is slightly lower for both groups, as epinephrine inhibits the absorption of the medication. There are some problems that are associated with the injectable anesthetics, including discomfort with the injection. Some of the ways to minimize this pain is to add bicarbonate, a 1 milliliter solution of 8.4% sodium bicarbonate for 9 milliliters of the anesthetic does help. Not only that, this moves the anesthetic into its more active component more quickly in the tissue. Infected and inflamed tissues create a more acidic environment, and the anesthetic doesn't move into its appropriate active component, and the bicarbonate will help with this. Other considerations is to use a small needle and inject slowly. Inject through the edge of the wound rather than through the skin surface. And in some cases, warming the anesthetic agent has been helpful in terms of the discomfort that the child experiences. We've already discussed the onset and duration. It's important to consider as one uses these agents in the office or the emergency room. Rarely the clinician is confronted with a child or family who might have a lidocaine allergy. In that instance, one of the things to consider is the ester family of local anesthetics, including procaine and tetracaine. If a true anesthetic allergy exists, or the concern of the parents is such, one could consider a 1% diphenhydramine injection. This has a much slower onset of action, at least 5 minutes, and there's often more pain associated with it, and buffering does not help with the pain with injection. Other resources may need to be considered if there is a lidocaine allergy, and that includes dissociative anesthesias such as ketamine, as well as general anesthesia to appropriately treat the child. For the best alignment of the wound and some decrease in infection, it's appropriate not to remove much hair. Things such as surgical lubricant and petroleum jelly can flatten the hair and keep it off the field as one addresses the wound itself. Once the clinician is satisfied with the condition of the wound bed, it's important to irrigate, one of the most important treatments in removing infectious risk from the wound. One of the things as I prepared this talk is the use of the high pressure irrigation has been shown to be much more effective than low pressure irrigations, which I was taught. High pressure irrigation includes a 35 to 60 milliliter syringe associated with an 18 to 20 gauge needle, and the clinician then injects it into the area to wash the wound away. Higher pressure systems will actually drive the foreign material into the underlying soft tissue, whereas lower pressure systems such as bulb irrigation or using saline bags and squeezing a saline bag at the wound only generates approximately 1 to 3 psi, which is insufficient to wash the foreign material away and therefore places the wound at greater infectious risk. Some authors have argued that the wound needs to be irrigated with 60 milliliters per centimeter of wound surface, and that seems a reasonable amount, although most clinicians will irrigate even more. Sterile saline has historically been used and continues to be used in most centers. Potable water appears to be equivalent in recent studies, and it certainly would be important in terms of wilderness or emergency treatment of the problem. Some things that one would intuitively think would be better includes betadine, hydrogen peroxide, and hypochlorite solutions or Dakin solutions, but these should be avoided because of the underlying potential for injury to the fibroblasts that will help the wound to heal. It's important to remove gross foreign material from the wound if it can be seen, and I think this is where imaging has been particularly helpful, as the clinician is then aware that foreign material may be present in the wound and should be removed. Finally, the underlying soft tissue that is obviously compromised and necrotic should be removed, as it creates a nidus for infection. However, skin itself should not be removed unless it's clearly ischemic and separated from the edges. This can act as a biological cover, even though scar revision may be needed in the future. Alternative skin closures include steri-strips and the superglues. In general, most traumatic wounds that come to the clinician's attention are not candidates for surgical tape closure. This closure method is indicated for wounds that are typically short, linear, and usually best not through the dermis itself. The tensile strength of steri-strips does not match those of the cyanoacrylates, our superglues, or sutures. Most steri-strips do benefit by the use of additional adhesive agents, including benzoin or mastisol. These do help. However, both of these agents can be associated with allergic reactions to the underlying skin, which will then increase the infectious risk. Steri-strips themselves are not appropriate over hairy areas, and therefore steri-strips or our surgical tape closures are generally not indicated for most wounds that are seen for ER evaluation and closure. Whereas steri-strips may not be appropriate for most injury-related laceration, there's a definite role for the use of tissue adhesives such as cyanoacrylates. Cyanoacrylates were first described in the 1970s, but it was in 1998 that Dermabond was approved by the FDA for use on humans. These cyanoacrylates are divided into two primary families, with Dermabond being of the octocyanoacrylate family and Histocryl being the butyl cyanoacrylate family. There are several other trade names that are available for these agents. The cyanoacrylates have a tissue strength and tensile strength similar to wounds that can be closed with 5/0 sutures. It's exceptional for most facial wounds, although one has to be careful around the areas of the eyes. minimal training, although some training is obviously indicated in the applications of these glues, as I can tell from personal experience. I was using one of the butyl acrylates in a wound and noticed how flexible and runny it was, seemingly running away from the area of wound. And when one applies it appropriately, it has a terrific application, stays well on the area of the wound, and does provide a good seal. There's much less patient anxiety, and that's been shown clinically and in the literature. However, cyanoacrylate should not be used on dirty wounds, so that a clean wound can be closed with the superglues, but dirty wounds will actually have a much greater infectious risk if closed with the superglues. There is greater dehiscence if it's used over a high tension wound, so a gaping wound typically will not support a cyanoacrylate closure unless the subcutaneous tissue can be closed to take tension off the wound edges. There are a couple considerations, which include no washing for 10 to 14 days in terms of immersion, but one can shower after 48 hours. There is some literature that is suggesting that petroleum-based topical antibiotics are important for wound healing, but in this particular instance with cyanoacrylates, the petroleum-based topical antibiotics will cause breakdown of the wound edges and lose to loss of tensile strength of the superglue. The most common treatment of significant lacerations at this time include suturing. It obviously increases the wound's tensile strength, it approximates the skin edges for an aesthetically pleasing and functional result, and it minimizes the risk of bleeding and infection that can occur with an open wound. Choosing a suture, the clinician will have to decide exactly what type of sutures are needed and where they're going to be placed. In most instances, absorbable sutures are being used in the underlying soft tissue and subcutaneous tissue, whereas permanent sutures are used on the skin. There are some absorbable sutures that are monofilament, but most permanent sutures are monofilament, and the braided sutures are most typically absorbable. One needs to determine the size of suture material that is necessary, as well as the needle type that is appropriate for the wound closure. The monofilament is important in that it has an inherent memory, so it needs additional knots, typically 4 to 7 knots. The knots slip easily as there's increased plasticity and there's less deformability of the knot, so the knot tends to want to return to its natural shape. It creates less inflammation and therefore is better in terms of being on the skin, as there is less infectious risk created by the suture passing through the skin, and it does not hold on to bacteria and does not act as a safe reservoir. The braided material does not have memory, so it needs fewer knots. The knots don't slip, so this is great for blood vessels in areas of high tension. It may create more inflammation, particularly if it's brought through the skin, and there's greater risk in the braided or twisted suture material of harboring bacteria. Common suture material include Vicryl and Dexon, which are long-chain sugars that require 4 knots into the minimum, and I usually tell our house officers 4 to 5 knots. The retention time is typically 60 to 90 days with 50% tensile strength retained for 3 weeks. Silk is a non-absorbable suture. It requires the fewest knots as it has terrific memory and will retain the knot shape for a prolonged period. So silk will only need 3 knots. Nylon, Proline, and PDS are suture materials that have a lot of plasticity, and as a result they do not retain their knot shape, and they therefore need many more knots to hold, usually 6 to 8. These are non-absorbable in terms of nylon and Proline and will need to be removed, whereas PDS, which lasts 180 to 230 days, most typically will need to be removed for most wounds, but it is a strong absorbable suture that can be used for holding fascia together. Chromic and gut were the old standbys. I actually am a big fan of gut. The fast-absorbing gut lasts 3 to 7 days and almost never causes tracking on the skin surface. Chromic does have some inflammation. Chromic is a sodium chromate salt that is added to the collagen that is used in the gut suture. This gives it greater strength, but also causes more reaction. There's possibility of allergic reaction with past exposure to chromic sutures. Monocryl is a new synthetic monofilament. It requires at least 5 knots. It retains its tensile strength for a short period of time, although the knot itself will remain for several weeks to even months. In general, we typically will use Vicryl or Dexon sutures in the subcutaneous tissue. And on the skin, I would most typically use nylon, although in young children where removal of the suture may be difficult, the plain gut ends up being a real advantage. One of the important things for the clinician to remember, obviously, is that dyed absorbable sutures should not be used on the skin, as there may be some tattooing. The suture material itself can be chosen based on size. For most large surface areas, such as trunk and extremity, a 4-0 suture is appropriate. For the face, 5-0 or 6-0 is used, and in very sensitive areas, such as around the mouth and eyes, I often use 6-0. These areas have relatively tension-free skin, and the closure is appropriate with this smaller suture, as it will hold and give a more cosmetically appropriate scar. The scalp tends to have more tension, as does the soles of the foot, and the larger suture is needed in that instance, such as a 3-0 or 4-0 suture. The needle itself is also important. A tapered needle is used in the subcutaneous tissue as it does not have any cutting properties. The cutting needles are used on the skin, and there are both reverse and standard cutting needles that can be used. The packaging is very helpful, as there is a fair amount of information for the clinician and health personnel to identify what suture they're going to be using. In this instance, the Ethelon suture is a nylon suture. It is a reverse cutting needle, as seen here. The needle size is often demonstrated on the package cover. It describes it as a monofilament, and it also describes its color. When one is sewing on the scalp, for example, a blue color may be more obvious and make it easier for the clinician to remove the sutures. Similarly, on this package cover, it's a Vicryl suture, which, as you may remember, is one of the absorbable sutures. The size is slightly larger than the 5-0, so the 4-0 suture is larger than 5-0, 3-0 larger than 4-0. This is not a cutting needle. This is a tapered needle, so that the point comes to a point, but it's round and it does not cut through skin. This would be difficult to pass through skin, although the clinician can do it, but it is much more difficult. This one's identified as an undyed braided suture. Our suturing principles include that deep lacerations typically benefit by more than one layer. This helps to prevent dead space in the underlying soft tissue, which can act as a point for fluid collection as seromas and can subsequently become infected. It's important to use landmarks on the skin to line up closure, particularly in areas around the eyebrow and orbital rim. The clinician should try to penetrate as much as possible at 90 degrees of the needle to the skin edge, as that will give us our best suture and best approximation. The clinician also should try to invert the skin edges slightly, because this will allow for a better scar, as the scarring process itself causes contraction and will tend to cause the scar to withdraw or sink in, whereas slight eversion will lend with a level surface. Approximate, don't strangulate is something that all of us have heard over and over again. It is important, as approximation of the edges of the deep tissue or wounds help to close the dead space and promotes appropriate inflammatory response and healing. Excessive pressure on the suture material, what my professor used to describe as strangulation, creates area of ischemia and tissue damage, which may lead to greater risk of infection. The position of the needle should be at the tip of the needle driver, and this is important. Many times one feels that the needle should be back in the needle driver slightly, but the needle drivers are specifically designed to hold the needle right at the tip. If you're back into the jaws of the needle driver somewhat, that'll actually impede the clinician's ability to close the surface area appropriately. When one is placing a needle, one would typically hold the needle 1/2 to 1/3 of the distance from the swage of the needle to the tip. The swage is described as that point where the suture material enters the needle. Once again, position the needle at almost a 90-degree angle to penetrate the surface, as that will give one the best scar and best approximation of tissue. The type of sutures that are used are can vary depending on the wound. Simple interrupted sutures are perhaps the strongest and most regularly used. A simple running suture can be used on the skin. It can be used on the underlying fascia if the area is cleaned, such as when one is in surgery. But most typically with traumatic lacerations, it would be inappropriate. However, if one has a moderate-sized wound that has little or no tension on the skin edges and the wound itself is relatively linear, a simple running suture can be helpful. The vertical mattress suture is one that can be used both as a single layer and as a deep and skin layer closure. Wounds need to be under tension or uneven for us to use this suture, as it is not practical in most instances. The vertical mattress suture can be faster than an interrupted suture if one is using it to close several layers. Horizontal mattress sutures are rarely used. However, they can be used in those areas where skin is under tension and there are bleeding edges, and what comes immediately to mind is the soles of the feet and the scalp. This is a diagrammatic representation of a simple interrupted suture. As one can see here, the stitch is placed through one side, brought out through the other side, and then secured as a knot. Despite this figure, I actually prefer to have my suture right at the subcutaneous dermal junction, so my suture would actually be placed slightly lower. One of the important things is with this 90-degree entrance is one sees one is approximating the entire wound edge, whereas if one comes in at a more acute angle, one will not tend to close the dead space as well. The continuous simple running suture is actually with a knot placed at one end, and then the clinician brings it across to the opposite side very quickly, closing the wound as a single layer. This knot works well, but once again, it is intended for relatively short wounds that are not under unusual tension. The interrupted vertical mattress does decrease tension across the wound. As one sees in this portion of the diagram, the clinician has placed the suture so that it goes all the way through the subcutaneous tissue to the underlying fascia. The important part and the difference between the vertical mattress and the simple suture is that the suture material passes fully through the wound, and then one comes through the dermal-epidermal junction on each side, and this helps to evert the wound edge and give a better appearance as the edge is everted slightly, as shown in this diagram. Finally, the horizontal mattress is once again for those to minimize tension across high-tension wounds. One takes a bite from one side of the wound to the other side, incorporates a portion of that ipsilateral side, and then comes back to the original side, closing the knots. As one can see, as one is holding much more tissue in the suture, one is able to approximate large areas. Wound care. Once the wound is closed itself, it should be covered for 24 to 48 hours, and it can then be exposed to air. For some children, particularly if clothing is striking the suture material, it would be appropriate to continue to cover thereafter. There is no need for antibiotic ointment, at least in children, although there is some literature in adults to suggest that prophylactic antibiotic treatment does help to minimize the risk of infection. However, in a small series of children, this was not shown to be true, with each having a 3% infectious risk. After the dressing is removed, it's appropriate to wash with soap and water, and then depending on the suture type, one can make a decision when bathing and swimming would be appropriate. In general, permanent sutures such as nylon or Prolene can be immersed fully after 48 hours once the wound edges are approximated. With absorbable sutures, because there's weakness, 5 to 7 days would be a more appropriate time before one fully immerses the suture material. In terms of suture removal, one could consider removing the permanent sutures placed on the face at 3 to 5 days, the scalp and trunk at 5 to 7 days, and extremities 7 to 10 days, although my personal preference is to leave it as long as 14 days, particularly if the area is over a joint. Another wound, as mentioned at the beginning of this discussion, is mammalian bites. The incidence of dog bites is by far the greatest. But the infection rate for a dog bite is actually somewhat lower than it is for cat bites or human bites. If one looks at a large series of wounds that present in the emergency room, dog bites will account for 85 to 90% of the wounds. Cat bites will account for 5 to 10% of wounds, and human bites between 2 and 3%. Some series actually report rodent bites, and there is an infection rate, although I couldn't discern one in the literature. But rodent fever, which can occur 3 to 4 weeks after a rodent bite occurs, is related to a streptococcal infection, and it is a potential issue. Although some are arguing that uncomplicated dog bites to the head and neck area may not need antibiotics, I would argue that all mammalian bites should be treated as infected and antibiotics should be prescribed. The type and choices include amoxicillin clavulanic acid, which is a terrific antibiotic as it has such a broad spectrum, and it covers most of the bacteria that will be seen in the oral pharynx of dogs, cats, and humans. The typical dosing is approximately 30 to 50 milligrams per kilogram per day in 2 divided doses. If a penicillin allergy is noted for the patient, clindamycin with trimethoprim sulfamethoxazole is also an appropriate treatment for these type of wounds. Human bite wounds in which a clenched hand, or fist as I used to call it in my youth, strikes the mouth can lead to a large inoculum of polymicrobial bacteria entering into the wound, even though the wound may be small. In some instances, even a portion of the tooth may be embedded into the wound. This can be a setup for disastrous hand infections and needs to be treated aggressively, possibly even with intravenous antibiotics such as Unicin, opening the wounds with irrigation and debridement, and a delayed primary closure. So should we close all wounds? Well, not all wounds, but certainly in children, almost all wounds. Wound dressings are uncomfortable, and one needs to consider that. Delayed primary closure can lead to a tenfold decrease in wound infection, particularly if the wound is noted to be infected or extensively contaminated. The purpose of delayed primary closure is to close the wound after the initial tissue response has moved from the early inflammatory stage into the proliferative stage. This typically will occur in the 3rd to 5th day after the injury, and will be manifested by the appearance of healthy appearing tissue in the wound, generally as granulation tissue that will appear slightly red, although not heaped up. This type of closure should be considered in the rare contaminated wound with a delayed presentation. As mentioned at the beginning, it's very difficult in children, however, as the dressing changes are painful and the children usually do not tolerate that well. Healing by secondary intent or secondary intention is also a reasonable choice for some small wounds. Extensive wounds typically will not have as good a scar if we let it heal by secondary intent and will need some scar revision in the future. However, small wounds on the hand have been demonstrated to heal equally well as to those wounds that were closed with sutures. This most typically is used only if there's a very delayed presentation to care. So in summary, if one is thinking about wounds, I will make the argument that most wounds in pediatric patients can and should be closed. What one needs to consider is patient factors, including age, particularly under 1 year of age and even more so under 6 months of age. Think of those children who are on steroids or chemotherapy for any reason, the rare child with renal failure or severe diabetes mellitus, and the occasional child with malnutrition. Wound factors tend to be more problematic in most of the children. Presentation greater than 10 hours of injury is the cutoff point that is currently recommended in most of the emergency room literature. A dirty wound has to be considered, and the possibility of good irrigation will allow a primary closure or a delayed primary closure. Foreign material, remember, vegetative material can be not seen on imaging but can be an issue, and the history is important in terms of the event. A crush injury or stellate wound won't heal as well, although I find in my practice that most pediatric patients who have these type of wounds do heal well. Necrotic tissue in the wound is a reflection of the severity of the crush injury most frequently. And remember that clenched hand or fist injury where one does strike a mouth can be a real problem for the clinician treating the issue. Cyanoacrylates are effective, particularly in the appropriately chosen wound. There's much less patient anxiety, it saves time. For small wounds, it's cosmetically equivalent, and it will actually save cost in the encounter. For more complex wounds, one may need to consider repair in the operating theater or with a dissociative anesthesia for the best possible result. Delayed primary closure or even healing by secondary intention may be appropriate in rare cases in the pediatric population, and the clinician should keep that in mind.